Yes, ladies and gentlemen, I also welcome you. And I wanted to introduce you to another case from my patient population, where I also used an artificial iris. But to what you have now heard, I had to go one better, so to speak, because the endothelium was also defective. And it's about a 58-year-old man who used to be highly myopic and now only saw 1.0 and zero point 0.4 in his left eye. Pressure was a bit borderline high and he had an Artiflex lens inserted, which virtually corrected the myopia, and this had been exived very early. Repositioned several times, and he saw traumatic mydriasis. You can now see the right eye and the left eye here. These are the initial findings. The lens is slightly subluxated. When he came to us, about 20 years after implantation, and the following pathologies were to be seen. We had the traumatic mydriasis, then 100 endothelium epithelial decompensation. Now also a cataracta complicata, and all this through the subluxated lens. And how can this be solved now? Now here already intraoperatively, I made this lens explanted in normal phacoemulsification. Then, as you have now heard, implanted a capsule tension ring, implanted the artificial lens, implanted the artificial iris, and then put a DMEK on it. And you can see the whole thing here now, where I removed the lens which is now excavated on the other side. Then come the lenses, the phacoemulsification tension ring, the implantation of our standard lens, and then comes the implantation of the artificial iris in the capsular bag. I did that with a disposable shooter, and I wanted to show you that again in the context of this little video. The artificial iris needs to be adjusted as you have heard. I made the white-to-white distance 2 millimeters and put them in a shooter, this artificial iris, so we can also fold them. That's what you've just heard. This also works quite well because this is a bit dark, but I hope you can still recognize it. If you have trepanned well, nice in the middle, then it will also orient itself very nicely centrically. And then the dripping of the decimet and then the careful unfolding of the DMEK was really very easy. And there were the concerns. The surface is a bit rougher, perhaps. And is that enough to preserve the endothelium as well? And I can confirm here that this is also possible, because in the end, the result is very appealing. The patient sees 1.0, has correspondingly less glare and is very satisfied. And he still needed a YAG capsulotomy. This can also be done. Then, through this little opening, and what I wanted to say, still? But I also knew beforehand that this would work to some extent, because there was a silicone diaphragm from HumanOptics here some time ago, which I had also used to compensate for this disturbed iris lens diaphragm. I only used it temporarily, unfolded the DMEK there, and then took it out again. And I already knew from my experience there that this works well, and that's why it was actually an obvious solution, that it now also works here with such an artificial iris, so that you can really say that the artificial irises of HumanOptics are of course suitable for the construction of the anterior segment of the eye, lead to a reduction in glare and make a better depth of field. It is all possible with minimal surgery, minimally invasive surgery. And then, of course, it also allows the patient not to come umpteen times, but also to combine these procedures. So, 3 implants. 1 transplant was quite a number. You don't do that in 5 minutes either. But it is possible to find an optimal solution for the patient. And then perhaps one could speculate that the artificial iris actually has an endothelium-friendly surface, at least to a limited extent, so that such things are possible.